Hello, good day everyone. I'm Saisa Silvermal, and I have recently graduated from University of Sri Jagannath from medical faculty. I'm going to start the ERPM classes on all the subjects in ERPM exams. As an introductory session, I'm doing some classes in all the main subjects. So as a topic, I'm going to discuss on chest pain today as an introductory session. This won't be a complete session on chest pain, but I'm hoping to do the complete session in future after if you are willing to register in my ERPM online classes. All the sessions will be given as recorded sessions, and in the future I'm hoping to do live Zoom sessions on demand basis. Okay, without delaying, I would like to start. So, chest pain. Chest pain is the most common case given in the ERPM as well as final MBBS examination. And when discussing about the theory topics, I will be telling you the important common MCQ points, as well as the questions they ask in the discussion and in the emergency vivas as well. All those topics will be discussed parallelly. And so note them because they will be helpful for you when you're doing your papers. And I will be going by module wise. So in the cardiology module, I'm going to start the chest pain today. And after each module, in all subjects, I'll be doing categorized MCQs discussions as well. So my further plans will be discussed for the registered students only. Okay, let's start. Ischemic heart disease. In ischemic heart disease, usually the ischemic heart disease, the patients usually given for the exams are non-STEMI, STEMI, or unstable angina patients. But in the discussions as well as in the MCQs, you will be tested about the basics. The difference is you know all the things, but in ERPM exams, the Sri Lankan setup is checked. So you should know what is done in government Sri Lankan wards. So that's the thing which differs from your knowledge and ERPM exams. If you know those simple things that are done in Sri Lankan boards, you can easily pass the exam because nothing deep knowledge is checked is in ERPM, only the superficial knowledge, and you should know everything, and you should be able to work as a safe doctor. This is not a postgraduate exam. This is a simple exam to pass to practice medicine. So you should know all the things to work as a safe doctor, safe house officer. Okay, in ischemic heart disease, there are chronic stable angina and other thing, acute coronary syndrome. Usually, the blood vessels which supply the heart muscles are blocked, and this is known as ischemic heart disease. And there's chronic stable angina, where the patient will be experiencing chest pain when on exertion only, but not at rest. This is known as chronic stable angina, which is a clinical diagnosis. And there are, on the other hand, there's acute coronary syndrome, which is quite a serious thing, life-threatening thing, and which is also discussed in your emergency vivas as well. Um, and in acute coronary syndrome, you have ST elevation, MI. That means ST elevation myocardial infarction, as well as non-ST elevated situations. In non-ST elevation, in the ECG, there will be ST depression or T inversion, or the ECG might be normal. So, with the ECG, we can't actually tell which type of non-ST elevation MI has occurred. So, then in the Sri Lankan setup, we do troponin. The troponin is done, and if it's a troponin is negative, we tell it's a stable angina, and if troponin is positive, we describe it as non-ST elevation myocardial infarction. Okay, let's discuss about those things in detail. There are angina means the pain, the chest pain. There are more types of angina. The one was chronic stable, and there is unstable angina. Unstable angina means these are recent onset chest pain, which means within 24 hours the chest pain has occurred, and patient will be presenting to the ward within 24 hours period. That means they can't tolerate the pain, and they will be um, presenting to the ward. And the patient may be previously stable, and he may be deteriorating within a short period of time. And usually unstable anginas occurs at rest as well, not only at exertion but also at rest. And there is another thing, Prince metal angina, this MCQ point, it won't be discussed in Vivas. And this Prince metal angina is occur due to coronary vasospasm. It means temporarily the coronary blood vessels, which supply the heart muscles, they contract. This usually occur in examples in Kawasaki disease, which occur in children. Coronary vasospasm occurs and they experience angina. Okay, then I would like to give you a case scenario, example case scenario, so that you can get a clear understanding about anginas. Okay, Mr. Y, 45-year-old with a background of hypertension uh, and type 2 diabetic mellitus, presented with central chest pain on exertion for 4-week duration. Note here, usually in your cases, you will be doing observed history taking. So, after observed history taking, they will be mostly asked the summary of your history. They won't ask a complete history. So, this is an example of such a case summary. So, 45-year-old man with a background of hypertension and type 2 diabetic mellitus presented with central chest pain on exertion for 4-week duration. Here, the patient is having central chest pain for 4 weeks. It's not an acute condition. The patient describes this pain as a central tightening type chest pain with radiation to left upper arm and both jaws. Chest pain occurs exclusively on exertion. This is the salient point here. Exclusively on exertion, only on during exertion, the patient experiences pain of around 200 meters walking and never occurred rest. These are the salient point, never occurred rest and exclusively on exertion. The patient does not have any associated shortness of breath, angle edema. These are the features of usually heart failure. And the examination reveals you will be doing observed examination as well in front of examiners. So examination reveal you have to tell the important positives and negatives only in the case summary when they ask for the summary. The examination revealed blood pressure of 170 by 80 and the heart sounds are normal. The rest of the examination is unremarkable. This is the short, the expected summary. It won't take even a minute to summarize your history because you have to quickly go to the discussion because for the discussion there will be more marks and for the history taking examination The marks will be given only during the observed history-taking examination duration. So don't spend much time in telling your summary, because they already know the history. So you have to tell the short summary. So here, uh, then the discussion will be go on. Like then they will be asking what's the diagnosis. So here, this setup is chronic. This is called the chronic stable angina, because in chronic stable angina, um, the this because of this chest pain is exclusively on exertion. This he didn't experience chest pain while on rest. So this is a chest pain exclusively on exertion. That's why this is chronic stable angina. And then again, they will be asking, how would you confirm diagnosis? First, you have to tell differential diagnosis. Then they will ask for the best diagnosis, and they will be asked, how will you confirm the diagnosis? In Sri Lankan setup, the main aim is to, because we are developing country, the main aim is to reduce the cost for investigations, and with the good clinical knowledge, we should be able to diagnose the things, because we don't have enough facilities in the ward. So, with the when they ask the to how to confirm the diagnosis, you should be telling from the initial part. That means from the history examination, then only investigation. Don't jump directly to the investigation, because our clinicians don't like the students are telling investigation as the first thing to diagnose. Diagnosis actually means from the history, examination, and investigation. Okay. So this diagnosis can usually made by proper clinical evaluation. The proper clinical evaluation includes detailed history and the examination. If a clear history is obtained, no further investigation needed to confirm the diagnosis. Okay, because this chest pain is exclusively on exertion, so it's probably a chronic stable angina. You don't need any investigation to confirm. When the history, if the history is, sometimes the patient won't tell the history uh, completely. So if it is inconclusive, we will be doing investigations. For that, we usually check the stress testing of the heart. For that, there are exercise ECG and stress echo. They will never ask how will you do the exercise ECG and how will you do the echocardiography. Those are all key things. These things won't be checked in your ERPM exam. So there are options exercise ECG as well as stress echo. Don't just tell ECG and don't just tell echo, because they expect complete answer. And if you are telling the incomplete answer, they will be asking more and more questions in to try to make you tell the complete answer. So it's mere time waste, and you can't score more marks in your cases and vivas. So at the beginning, practice tell complete answers. So okay, the exercise ECG and stress echo is enough. In in some patients, we might go for CT coronary angiogram. This is an expensive investigation. So, in stable angina patient, when we'll be doing the CT coronary angiogram, don't tell CT coronary angiogram as the first investigation. Then it will be a disaster. The CT coronary angiogram, it will detect the calcium in atherosclerotic plaques, and it can detect it will be detecting uh, coronary lesions with high sensitivity. So, however, the rate of detection of significant obstructive lesions may be poor. So, CTCA, that means CT coronary angiogram, and it may have an application as a tool for a negative prediction. So don't tell CT coronarogram angiogram in a chronic stable angina patient as a first investigation. Tell exercise ECG and stress echo as a first. And if they ask, is there any special investigation? If they ask only, tell CT coronary angiogram. Otherwise, don't tell about that. Okay. Usually, chronic stable angina is not given at the exams, but they can ask in the discussions, as well as they can ask in the MCQs as well as an SBS. Okay. Then you have to discuss the management of a patient with chronic stable angina. When they are asking about the management, don't jump directly to the pharmacological management. You have to always categorize your answer. And when for the management of chronic stable angina in any disease, first we have to inform the patient and reassure that this angina has good prognosis. This word itself cure the half of the disease. So first you have to inform and explain about the condition to the patient. Then there are non-pharmacological as well as pharmacological management. You tell the answer like this better: the lifestyle modifications and management of other comorbidities, because the patient might be having other diseases. In this patient, he is having hypertension, diabetic, like that. So lifestyle modifications, the lifestyle modifications means advise the patient to reduce the saturated fats intake, total fat intake, and refined sugars. They should stop them or reduce them. And if he's smoking, he have to stop smoking, and he should exercise moderate. If it is a moderate exercise, 150 minutes per week, and if it's a vigorous exercise, 75 minutes per week. Like that, you have to advise these things. You should be able to tell quickly when the examiners ask. And you have to stratify the risk of the patient for the further management, the cardiovascular risk the patient have, because you will be collecting all the details in the history. So after that, you can stratify. And let's move on to the pharmacological management of chronic stable angina. Remember, this is not the management of STEMI or non-STEMI or unstable angina. This is for chronic stable angina. I will be discussing about acute coronary syndrome and their management later. Okay. For pharmacological management, you can tell the class of the drug and the example. Because usually if you tell the class of the drug, the next question will be definitely what's a drug. So it's better if you tell the class of the drug and along with the common drug used in Sri Lankan setup. Okay, we are using antiplatelet therapy for the chronic stable angina, and for the antiplatelet therapy, usually in the Sri Lankan setup we give aspirin alone. Don't tell dual antiplatelet therapy, that's for acute coronary syndrome. Don't mix up chronic stable angina with acute coronary syndrome. Aspirin alone and clopidogrel. If the patient is intolerant to aspirin, you will be giving clopidogrel. The combination, that means aspirin as well as clopidogrel, has no effect. There is no proven benefit in chronic stable angina. So then you should know which drugs have survival benefit. What's survival benefit? There are many in MCQ points. These are main MCQ points. This drug has survival benefit. It means after doing research only, they have found that some of the drugs in some of the conditions they have survival benefit. So without the research evidence, we can't say survival benefit. So aspirin has survival benefit. It has survival benefit in chronic stable angina. Aspirin, the aspirin has survival benefit in chronic stable angina, but we can't say we can use aspirin for any disease for the survival benefit. It's wrong. It Aspirin has survival benefit in chronic stable angina. So those things you have to be clear, because those are the things that are checked in common MCQs. So there is no dual antiplatelet therapy in chronic stable angina. The next drug is statin. We usually give high dose statin, 40 milligram. We give high dose statin, and this statin is given for plaque stabilization. There is atherosclerotic plaques for plaque stabilization. This statin also give survival benefit. Then acetylcholine, sorry, ACI inhibitors, which means ACI inhibitors. They are enalapril, captopril, those are things. These things also have survival benefit in patients with ischemic heart disease, particularly those with diabetic mellitus, hypertension, and early stage of CKD and associated heart failure. Then we have anti-anginal medication. Remember, these anti-anginal medications don't have survival benefits. So these are main MCQ points. So in chronic stable angina, the drugs with the prognostic benefit or survival benefit are antiplatelets, statin, and ACI inhibitors. Okay. The anti-anginal medications, their primary role is to reduce the cardiac ischemia and symptoms of angina. Okay, there are several classes of anti-anginals. As I said before, you should be able to tell the drug, not only the class. There are nitrates. In nitrates, there is DTN, ISMN, ISDN. There are short-acting preparations such as GTN. They are used sublingual for immediate symptom relief. And these nitrates, they act via systemic vasodilatation, which reduce the end diastolic volume. And they dilate because those blood vessels are somewhat obstructed by plaques. And not completely, but they are somewhat obstructed to a point. So we should dilate them so that we can give the blood supply for the heart muscles. So dilation of epicardial coronary arteries via nitric oxide and subsequent increase in cyclic GMT. You might think that do we need complete pharmacology knowledge to pass the exam? No. You should know only the selected drugs we use, and you should know the basic pharmacology. I will be telling the basic pharmacology you need in every aspects, in every sessions. That's enough for that. And the basic physiology, pharmacology, microbiology, all those are the paraclinical things. You should know only the, you have to know only the simple things. You don't need a deep knowledge to pass the clinical exam. So I will be discussing the important points here as well. So here, if they ask what's the nitrate is doing, you just tell they are systemic vasodilators. They reduce the end diastolic volume and they dilate the epicardial coronary arteries where nitric oxide. These are enough. They reduce the vasodilate and they reduce the end diastolic volume is enough for their clinical exam. And there are side effects. For every drug has side effects. They might ask, and it's usually tested in MCQs. Adverse effects are headache, postural hypertension, and if it's a long acting preparation, the patient might get tolerance to that drug. And long acting preparations are usually ISMN and ISDN. Okay. Then the next anti-anginal medication is beta blocker. Usually, it's used in all patients if there's no contraindications for beta blocker. Remember, in vivas and your case discussion, you should have the control within yourself. I mean, if you tell something, they will be asking the next question from the answer you told. So tell the answer that you know if they ask further questions on that answer. Okay, so if you tell that there are nitrates, beta blockers, calcium channel blockers, definitely they will ask what are the nitrates, so what are the beta blockers used, what are the calcium channel blockers used. So be ready to tell that answer. So don't tell something you don't know, tell something you know, because you should show your knowledge that you have knowledge and you are safe to work as a doctor. So always when you're telling the answers, keep that in mind. For beta blockers, if there is no contraindication, if you tell I'll give beta blockers if there is no contraindication, then the next question will be, so tell me what are the contraindications for beta blockers. So if you are telling any answer, be prepared to answer the next question, and you should be knowing which would come as the next question. Then you can easily pass your vivas and cases. That's the only thing. In medicine, the consultants expect a safe superficial knowledge. They don't expect deep knowledge, and they don't prefer people talking more time without any points. So be brief in your answers. Like beta blockers, you should try to restrain heart rate to 50 to 60 beats per minute, and it's there's no survival benefit in chronic stable angina for beta blockers, but there is survival benefit for beta blockers in myocardial infarction. That means in acute coronary syndrome, there is survival benefit. This is a difference, because some drug will be having survival benefit only in a certain disease, but not in all the diseases. One such example is beta blockers have survival benefit in acute coronary syndrome, but they don't have survival benefit in chronic stable angina. These are the important salient points tested in MCQs, and these are things you should remember. So when studying, mark those important things. Then calcium channel blockers. Out of all calcium channel blockers, only verapamil and diltiazem are anti-angiogenics. So they also cause coronary vasodilatation and reduce the myocardial oxygen demand by reducing the myocardial contractility. Diltiazem is a commonly used drug, also verapamil. The dihydropyridine calcium channel blockers such as nifedipine, they should be avoided because they may cause tachycardia and worsen the symptoms. So if they ask in MCQs, nifedipine is used as an anti-anginal in chronic stable angina, the statement is wrong, because though nifedipine is a calcium channel blocker, that's not usually used in chronic stable angina. So these are the things tested in MCQs, but they won't ask those much deeper things in cases. Other medications, they are also available. They are second line medications, but they don't have any survival benefit. Second line medications are used when first line medication, the above 4 drug class I told before, are the first line medications, which are things the antiplatelet therapy, statins, ACE inhibitors, anti-anginals, those are the first line medication. Then the second line medications, they will be they reduce the symptoms and they are used if first line medication fails. There's one such examples are nicorandil. It activates ATP sensitive potassium channels. You don't need, they won't ask these deep, and they won't ask this in MCQs as well, but just for the knowledge being that there are second line medications such as nicorandil, ranolazine. The ranolazine inhibitor involved a sodium channel current in the myocyte is contraindication in patients with hepatic failure, because these are MCQ ones. The MCQ I have noted are the things that have occurred in your final MBBS exam papers. And if your patient might be having hepatic failure, so you can show your knowledge in the cases. As this patient is having hepatic failure, I won't give analysis like that. And as your patient may have other comorbidity conditions, assess the suitability of about drugs always. Because if your patient, these are MCQ points. If your patient is having heart failure, you should avoid diltiazem and verapamil. Amlodipine and lorenzin may be safe. These are MCQ points. And your patient might be having peripheral vascular disease. For that, calcium channel blockers are favored as beta blockers can cause peripheral vasoconstriction. So in those patients, you should avoid beta blockers and you can use calcium channel blockers. And the next management I told before, that risk stratification and further management. Patient with chronic stable angina, they should undergo risk stratification. The tools used for risk stratification are echo, stress ECG, stress echo, and in some cases, myocardial perfusion scans. But this is not routinely done in Sri Lanka, so don't tell myocardial perfusion scan as the very first investigation or risk stratification tool. And patients who are symptomatic despite optimum medical therapy. Optimum medical therapy means you have given the first line medication, you have tried with the second line medication, but still the patient have symptoms. Despite the optimum medical therapy, if the patient is having symptoms, and those who have high risk hope, they should be referred for the invasive coronary angiography. And if the patient having aortic stenosis, there's absolute contraindication for exercise ECG, and there's a contraindication for ACI inhibitors as well. This all about this. This all that you need to know in the chronic stable angina. Usually, chronic stable angina is not given for the cases. So then I'll be discussing about acute coronary syndrome and further things in future classes. And that's all. And if you want to contact me for further details, you can always WhatsApp me. And my WhatsApp number is okay. For further details, you can always contact me. Okay, thank you. That's all for the introductory medicine session. I'll be discussing other things in my future classes. Okay, thank you.